Hello and welcome. Today, we're diving deep into a serious and often misunderstood condition, pulmonary arterial hypertension, or PAH. We'll explore what it is, why it happens, and what can be done about it. Our focus will be on idiopathic, heritable, and drug-induced forms of this complex disease. So, what causes PAH? In many cases, called idiopathic PAH, the precise cause remains a mystery. It develops spontaneously without a clear trigger. Heritable PAH, on the other hand, stems from genetic mutations, often affecting the BMPR2 gene, but also others. These genetic changes predispose individuals to developing the disease. Finally, drug-induced PAH is linked to certain medications and toxins. Some appetite suppressants, recreational drugs, and rarely other medications have been implicated in triggering PAH in susceptible individuals. It's crucial to note that not everyone exposed to these substances will develop PAH. Let's understand what happens inside the body with PAH. Normally, the pulmonary arteries carry blood from the heart to the lungs to pick up oxygen. In PAH, these arteries become narrowed, thickened, and stiff. This increased resistance forces the right side of the heart to work much harder to pump blood through the lungs. Over time, this overwork leads to right heart enlargement and eventually, right heart failure, also known as cor pulmonale. This decreased blood flow leads to decreased oxygen supply to the body, causing shortness of breath, fatigue, and other symptoms. Pulmonary arterial hypertension is considered a rare disease. Idiopathic PAH affects an estimated 1 to 2 people per million each year. Heritable PAH accounts for about 15–20% of all PAH cases. Drug-induced PAH is even less common, but its occurrence highlights the importance of medication vigilance. PAH can affect people of all ages, but it's more frequently diagnosed in women between the ages of 30 and 60. The symptoms of PAH can be subtle at first, often mimicking other conditions. As the disease progresses, symptoms become more noticeable and debilitating. Common signs and symptoms include shortness of breath, especially during exertion, fatigue and weakness, chest pain or pressure, dizziness or fainting spells, particularly during physical activity, swelling in the ankles, legs, and eventually abdomen, a bluish tinge to the skin or lips, called cyanosis, and a racing heartbeat. Because these symptoms are non-specific, diagnosis can often be delayed. Diagnosing PAH requires a thorough evaluation, as no single test can definitively confirm it. The process usually begins with a physical exam and a review of the patient's medical history. Doctors may order blood tests to rule out other conditions. An echocardiogram is often the first imaging test performed to assess the heart's structure and function. A right heart catheterization is considered the gold standard for diagnosing PAH. This invasive procedure involves inserting a thin tube into the pulmonary artery to directly measure the pressure inside. Other tests, such as pulmonary function tests, ventilation perfusion scans, and CT scans of the chest, may also be used to rule out other causes of pulmonary hypertension. While there isn't a single universally accepted classification for idiopathic, heritable, and drug-induced PAH specifically, they generally fall under Group 1 of the World Health Organization (WHO) classification of pulmonary hypertension. Group 1 encompasses pulmonary arterial hypertension, which includes these subtypes. Within Group 1, patients are further classified based on the severity of their symptoms, ranging from WHO functional class I no limitation of physical activity to class IV symptoms at rest. Unfortunately, there's no cure for PAH, but treatments are available to manage symptoms, improve quality of life, and slow disease progression. Treatment strategies vary depending on the type and severity of PAH. General measures include lifestyle modifications, such as exercise and diet changes, oxygen therapy to improve blood oxygen levels, diuretics to reduce fluid buildup, anticoagulants to prevent blood clots, and digoxin to help the heart beat stronger. Specific medications that target the pulmonary arteries include endothelin receptor antagonists, phosphodiesterase 5 inhibitors, prostacyclin analogs and prostacyclin receptor agonists, and soluble guanylate cyclostimulators. In severe cases, when medication is not enough, a lung transplant may be considered. Currently, there are no definitive ways to prevent idiopathic or heritable PAH. However, you can reduce the risk of drug-induced PAH by avoiding known causative medications and substances. Always inform your doctor of all medications and supplements you are taking and be aware of potential side effects. Regular check-ups and monitoring for early symptoms are also important, particularly if you have a family history of PAH or are taking medications associated with the condition. The prognosis for PAH varies depending on several factors, including the underlying cause, the severity of the disease at diagnosis, and the response to treatment. Historically, the prognosis for PAH was poor, but advances in treatment have significantly improved survival rates. Ongoing research is focused on identifying new drug targets, developing more effective therapies, and understanding the genetic and molecular mechanisms underlying PAH. Gene therapy and stem cell therapy are also areas of active investigation. Improved diagnostic techniques and earlier detection are also playing a vital role in improving outcomes for people with PH. Remember to consult with your healthcare provider for any health concerns and treatment options.